Today I have the pleasure of introducing Dr. Jason Porter. He is a medical oncologist / hematologist in thoracic medical oncology at the West Cancer Center in Germantown, Tennessee, where he is also the director of the Lung Disease Research Group. Dr. Porter earned his MD at the University of Tennessee Health Science Center College of Medicine in Memphis. He completed his residency at the University of Tennessee Health Science Center, followed by a fellowship in hematology oncology at the West Cancer Center, with the time also spent at the Division of Thoracic Oncology at Vanderbilt Ingram Cancer Center at Vanderbilt University Medical Center. Dr. Porter is a board certified in medical oncology. He is principal and sub-investigator for clinical studies related to lung cancer. His professional memberships also include ASCO and IAS, so the International Association for the Study of Lung Cancer, and he is an advisor for a variety of organizations, including research advisor for the Thoracic Research Group at Vanderbilt University and national medical advisor for 50 Hoops. Let's give him a round of applause and welcome.
Thank you so much. This is great energy. It's so exciting to see this, and I believe my administrative assistant and friend is on, and we have been having some discussions here at home. Even as recently as today, one of our meetings was with our foundation here to discuss advocacy and support for our patients in Memphis. And to hear from Australia, and so I can say in Canada, pretty much this is international. So this is super, super exciting. And one thing that some of my patients have come to me and said, just very clearly, I don't have anybody to talk to about my diagnosis, about my treatment, my side effects, any of, the decisions that I have to make for myself and for my family. And so to know that there are people that are out here, and I know that there are advocacy groups, and I know that there are support groups, and I've, met with many of them, but to here in my hometown. So I'm from Memphis, born and raised in Memphis, Tennessee, and went to high school here, college here, and also my medical school here, as you just heard from the introduction. So I've been in Memphis, except the little time that I spent at Vanderbilt, but then I came right back to Memphis because I feel like there's so much missing here. And so we're trying to put some of those pieces together. And this is rightly encouraging to see this and to get a chance to participate in this discussion tonight. So I hope that, I know you're on mute, but I hope there's anything that you want to discuss that you come off mute so that this can be a discussion and we can actually talk about things that matter to you, in addition to the research and the things that we have going on that we'll discuss tonight. My dad was diagnosed with small cell lung cancer when I was in college. And it was a very, very, different time in some ways, but then so similar in a lot of ways. As Dusty pointed out, we know small cell lung cancer still needs a lot of research, and there's a lot of work to be done in small cell. So the therapies now are not so different, but the addition of immune checkpoint inhibitors to extensive stage small cell lung cancer was, practice changing for us in small cell. So that's a big difference compared to when my dad was diagnosed with his disease. And, fortunately, I have some long-term survivors on their immune therapy maintenance. And my dad didn't have that. It was in 2001. So it was about, 22 years ago when he was diagnosed. And excited about the experience now, about the research now, about the opportunities and offerings, and the things that are coming down the line in small cell lung cancer. So, maybe we just get right into it. And I will say that one of the things that I'm most enthused about is the coming subclassification of small cell lung cancer. We know it's not all the same. A 28-year-old that's diagnosed with small cell lung cancer is probably not the same disease that my dad, who was a smoker and a welder and had a lot of occupational exposures. I would expect a different disease kind of biology and behavior from those two patients or those two demographics of patients. And so now that we're beginning to subclassify, and some of the researchers and some of the larger academic institutions are starting to really break down small cell lung cancer the way we have with non-small cell lung cancer, particularly adenocarcinoma. I get jealous every time I see the pie chart with all of the different oncogene drivers that we have characterized in non-small cell, particularly adenocarcinoma. And I just say, where is this pie chart for squamous cell carcinoma and for small cell lung cancer? And at what point are we going to be more aggressive about getting subclassification and subtypes, which will obviously change the way we approach certain types of small cell lung cancer and in certain patient populations. So that is something that I'm really interested in. We know that we do molecular testing for patients with lung cancer. And when we get molecular testing in small cell lung cancer, number one, I know of many people who aren't doing it, but we need to do it because the only way to discover the oncogene drivers or whatever is driving the various subtypes of small cell lung cancer is to actually see the trends in the mutation analysis that we do for these patients. And so I'm really pushing to have this done for all of my patients, molecular sequencing. But then the subtyping that's being done, and I don't know if you're familiar with it, but there are a couple of different iterations of it. And so what it looks at is there an inflamed subtype, and then other proteins that are being expressed from the cancer. I'm sure that you're probably familiar with it, but the long and short of it is when we do that, we'll be able to individualize care and personalize the care for even small cell lung cancer patients the way we have for the non-small cell lung cancers. So one of the problems is when we get our biopsies from small cell lung cancer, we know that it's often very necrotic tissue, and that tumor grows fast, but it also dies rapidly. And so the DNA and RNA and all of the nucleic acids that we need to study, and even the protein expression of proteins from the tumor, often suboptimal for studying and for analyzing the tumor at a molecular level. And because of that, one of the things that I'm really interested in and that I'm pushing to move forward in research in my center is to, when we know a patient has a diagnosis of small cell, not just get a needle biopsy or fine needle aspiration and then see small round blue cells and then go from there. What I really want to do when it's appropriate and when the patient can tolerate it is go in. We know a lot of times there's bulky mediastinal lymph nodes for these patients. Let's get a sample, a surgical sample. So do a thoracoscopy and let the thoracic surgeon go in and actually get a nice size sample from that tumor, where we can look at the heterogeneity right there in the lymph node or the tumor that's growing and get a lot deeper sequencing compared to what we have done historically. So I met with one of our thoracic surgeons and I talked about it, and I asked, how long after a thoracoscopy would you be comfortable with me moving my patient right into their chemotherapy? Because obviously we don't want to delay treatments, because we know that the treatments equal time for us in small cell lung cancer as rapidly as the tumor grows, and also given the fact that it's often diagnosed at an extensive stage, so it's already grown and metastasized for many people, unfortunately, before we get the diagnosis. So if we're going to do a surgical resection to get a nice sample of tissue to use for our molecular characterization, we don't want to slow down getting us onto therapy. So the surgeon says to me, I would be comfortable with you going on to do the chemo like the next day. It's a small incision to get in there and get to where the tissue is, and it shouldn't slow us down. So that being the case, I'm really moving forward with a plan to start a protocol where we can actually get a nice tumor sample instead of just what we get, the highly necrotic. Ki-67 is very high, so it kind of gives us that information that we need to confirm the diagnosis, but it doesn't let us really study the tumors. And so my friend, Dr. Wade Imes at Vanderbilt, is building a biorepository of samples that we can use to really study at the molecular level small cell lung cancer the way that we have non-small cell lung cancer. And I think this is really going to help us to figure out other ways to treat and to approach the disease, in addition to what we already have with chemotherapy, platinum and etoposide, and then the addition of immune checkpoint inhibitors now as a standard of care. We have lurbinectedin as a second line option now, but then we need options beyond that, and we need tailored options. We need to know who is really going to benefit from the immune checkpoint inhibitors without giving them the side effects that they may not be due if we can predict that they're not going to benefit. So that's one of the things that I'm focusing on right now. And before I go any further, because I can talk and I will talk for an hour. So I'm going to stop in case there are comments or questions, and then we can come back and talk about the next thing.
Yep, you did answer some of my questions along the way because I was wondering if they can get that subtype, because subtype I think is very new. So I guarantee you a lot of people on this call probably do not know what their subtype is.
Okay.
And I don't know if every center is doing it. So that's a good question. So how would the patient, number one, know how is it going to be spoken to the patient, the subtype, and is it going to be like you have an inflammatic subtype of small cell lung cancer, or how is that going to be spoken to the patient?
So that's the thing right now, we do, I don't want to necessarily promote any particular next generation sequencing, but CARES, Guardant Foundation, all of these companies that are providing molecular sequencing to us, they are not subtyping small cell. So we won't get a subtype on the next generation sequencing if it's being done in the small cell patients, unfortunately, right now. But in the research realm, Dr. Chapana Sen and also other people from different centers around the country, Charlie Rutten, are doing some of this work and subtyping and really classifying these tumors at a molecular level. And with that happening, eventually it will move out and be generalized. But I think right now, there's still Dr. Lauren Byers from MD Anderson, still people trying to figure out exactly what we do with those subtypes before we put the information out there. Because once we know it, if we don't really have anything to say behind it, it's number one, it's not that helpful. So once we know that inflamed subtypes are usually the ones who have that prolonged response to immune checkpoint inhibitors. So, but then there are other, there's overlap with some of these subtypes. There's tumor heterogeneity, where you may have predominantly one subtype, but then another subtype as a subclone. So we don't want to get ahead of ourselves, but at the same time, I think unless we really start to accumulate this information, we won't be able to differentiate these things and apply our therapeutics and therapeutic development kind of paradigms to the subtypes. So you probably won't hear about subtypes right now. When you go and if you're diagnosed and they're disclosing the information about the diagnosis, probably won't talk to you about subtypes. In a community practice like my own, it's not being done. So what I have to do is work with researchers like Dr. Sen and send her samples. And then I've been working and have had discussions with herself and Dr. Rudin about getting access to the antibodies to do the staining in our pathology lab at home at our cancer center. So that's one thing that we are working on, so that while the academics, because technically I'm in a community practice. So, but while they're doing their analysis, I can still, even in my community practice, be able to focus on subtyping and bring things to add back to the data that they're amassing in the academic realm. So it's really important, I think, that we start to do that. But right now, you won't hear much about your subtypes.
Yeah. Oh, yeah. We've had the benefit of listening to Dr. Sen. I know Dr. Rudin.
Yeah,
So
yeah.
very good. And I think you answered my other question too, that you don't necessarily have the tumor bank, but I didn't know you read that. That makes sense because you're at the community hospital, but you're in partnership with Vanderbilt, who they do have we know probably a large tumor bank.
Yes, yes. And it's not that we don't, because we also work with the University of Tennessee here in some capacities. So we do still have some banking here, and our center does a lot of research, phase 1, 2, and 3 research. But as far as the basic science goes, right now, I don't have a basic science lab, but I spent enough time in the lab at St. Jude that right now I'm a little bit burned out, and I'm okay if I don't have a lab right now. I'm focusing on my patients and their journey and experience, and my own journey and experience. So I think it will eventually lead me back to basic science. But right now, if you say the word pipette to me, I get a little twitch, and then I don't feel good for a few days. So I stay away from pipettes. And I don't even want to think about a gel electrophoresis or protein electrophoresis. All of those things I'm staying away from right now. But I did about 6 years of basic science at St. Jude along the way. And so I have my feel for it, and hopefully we'll eventually get back to it.
Oh, yeah, one more question, then I'll pass it on. So thank you for working at a community level hospital. We know a lot of patients, we don't have access to these large university-based, research-based hospitals. So how, if a patient on this call is being treated at a community-based hospital, how could they ensure that maybe that community-based hospital is partnering with the best research out there and that they are getting the best standard of care?
I think that as simple as it's going to sound, access to a medium like this is so important, because maybe you're not there, but maybe somebody else is there. Maybe Christine or Pamela, or Lindsay Cooper is there. And so if you are, and we're having these discussions, then obviously we can share that information. So, but there's a good number of people on this call right now. But if I think about clinic, just yesterday, that's clinic yesterday. So, where are all the other people, and are they getting access to this information? And and that's why I was saying earlier about bringing the support groups here to home, so that people will hear and will know, because word of mouth is still very, very effective. And if you don't know what needs to be tested or what needs to happen, then you go to clinic and you really can't hold your doctor accountable. And so I have worked on and designed some little basically checklists to give patients, to say, here, take this. When you go to your appointment, you got a new diagnosis of lung cancer. These are the things that should happen. And then they can say, they don't have to memorize it. They have their check sheet right there, and they can say, did I get molecular testing? Did I get an MRI of my brain? Did I get, and you can just go down the checklist and make sure. And it's, somebody I was talking to this about, and they were like, oh, we could create an app. And I was like, no. Make it simple, because somebody doesn't want to fool with another app, and somebody's still using a flip phone. So just give me a checklist, and I can put it right there in your face and say, you didn't do my MRI, or you didn't do my next generation sequencing. And so very simple, very easy, but still very effective way to hold people accountable. And then one of those questions could simply be, have you considered research for me? And we educate and we remind people that NCCN says the best cancer care is in a research clinical trial. And I think about the people who started on Opdivo and Yervoy or pembrolizumab, all of these drugs back when they were in phase 1-2 trials. Imagine how far ahead of everybody else they were when they got access to those drugs almost a decade ago, or over a decade ago now. That's clinical trial practice changing eventually, but so many people got access early and were able to benefit. And so, a lot of people are, and I try to educate here at home, are afraid of clinical trials. Are you just experimenting on me? What's going to happen? And then to really explain to people, even just that scenario that we just discussed with the immune checkpoint inhibitors, you could have had access to, what is going to be in 10 years, the biggest thing out there, and maybe it not only made you feel better, but even saved your life and brought you to that point where you get to see that now it is the standard of care. And so helping people to understand that, everybody doesn't. And one conversation I had with a patient the other day is, yes, some people don't respond to research drugs, but guess what? We don't even guarantee that you're going to respond to what's the current standard of care. So where there's something available out there, at least hear the science, at least hear the proposal for what the clinical trial is that's being offered. And so I'm trying to educate and bring those things to mind for people here at home. But definitely when we look at response rates, if response rate to any therapy is 100%, then by all means, just go on that therapy, and then we'll ride it out and get as much out of it as we can. But the truth of the matter is, if there's a clinical trial available, we should make it known to people, and people should at least hear about it. And so reminding people about their checklist, but then putting on their checklist, have you considered clinical trials for me? Is there anything available? And then just asking. I had a patient that has a non-small cell, full disclosure, but had neoadjuvant therapy and surgery, and in less than 2 months had relapse locally, and it's advanced relapsed. And so we were trying to do a re-resection and get that out of there, but it's adherent to his aorta. And so then we can't take it out. And he comes out and the same evening sends me a text message to say, hey, I know you spoke to the surgeon, but can you call me so we can discuss what we may be able to do next? And in doing that, I'm here in Memphis, Tennessee, and he asked about MD Anderson. And the first, thing that came to my mind was Dr. Cascone, and I sent her an email, and he's headed down to MD Anderson. He left this morning actually to go to MD Anderson and see what clinical trials are available for him there, because I know that right now I don't have anything that I feel comfortable with for him. But am I ashamed of that? No. Do I have pride that prevents me from sharing the information with him? Absolutely not. Because in meeting this guy, I met and made a really good friend. And he is a chicken farmer here in Tennessee, and he is fantastic. And his wife is so sweet. And when I look at him, I'm like looking at a brother or uncle. And I just want the best thing for you. I can't give you what I think you need. Please go see, where. And so we have to get rid of our pride. And, as doctors, kind of like airline pilots, there's a little complex there for some of us. And so we feel like, oh, I'm the best thing out here. And that is not the truth. This is a community and this is a village. And if we all work together, it's when we can really make a difference. So my hope is that he'll go down and find something that's really going to make a difference, because 2 years, 5 years from now, I want to still be visiting with him. I want to still be following up with him. And, as long as I'm honest and truthful about that, then it really keeps all avenues open. And it allows us to get really where we need to be. So if you're talking to a patient with a new diagnosis, or if you have a new diagnosis and you haven't heard anything about research, or don't be ashamed to ask. Don't be ashamed to ask for a second opinion. I got a list of people on speed dial that I will pay for your ticket. Go see this person and talk to them and hear about what's out there and what's available. Because if you don't, then at the time that we, maybe treatment's not working and we have a complex before us, I don't want to be sitting there wishing I had done something. Or I don't want my patient or their family to be saying, I wish we had just checked into this. Let's get it all out there and explore it. And really, we get to do it together, because I want to talk to some of those people too. So if I send you to see them, guess what? I get to talk to them. And so it's good for me too.
Yeah, I appreciate that. Thank you so much. This is not the experience a lot of people have. I did some research for lung cancer and how does the patient have conversations with their doctor. So I could see you would have high ratings. That's great. And I'm excited about what's coming down the pike for small cell and hopefully personalized medicine. So anyone else have a question? You could raise your hand or come off mute, or a comment. Okay. Okay. I see Rayanne first, and then I'm going to go to Wendy. You're muted, Rayanne. You're still muted. Maybe she can't hear me.
Okay. You got it.
Okay.
There we go. Dr. Porter, I'm 3.5 years after diagnosis with extensive small cell. I have either been on chemo or immunotherapy the entire time. I just started my second experience with lurbinectedin, or whatever Zepzelca is called in the laboratory. I'm reluctant to go to a clinical trial because I feel like I'm treading water and trying to keep my head above water with the treatments I'm getting. How do I overcome that fear?
Well, Ryan, number one, the fact that you're coming to your second experience with lurbinectedin is really important. And what I do is cycle through therapies as often as I can. So if you've been on platinum for a long time, or you've been off platinum for a long time, I'm going to re-challenge you with that. If you got to platinum and that lasted for a while, I'll go to lurbinectedin and I'll come back and switch through these. No problem at all. So I'm excited that that's the experience that you're getting, because a lot of people say, oh no, it didn't work, and they just kind of move on. But I will say to you, and maybe give you a anecdotal kind of scenario of one of my patients, one of my longtime survivors of small cell. And she had started with her chemo and immune therapy, did well on maintenance immune therapy for over a year. And at the time that she progressed, we had a clinical trial with a SN38 metabolite. That's basically the active part of irinotecan. And it was linked via a linker to a small molecule. So it was kind of a targeted chemotherapy, similar to like trastuzumab or, Herceptin in breast cancer. So she went on that therapy and was on that clinical trial for over a year with disease control with no side effects at all.
Mhm.
So the whole point of the targeted delivery was that irinotecan in its own, kind of original form causes a lot of diarrhea and a lot of side effects that, we want to try to avoid, and then figure out a way to deliver this SN38 without the side effects. And so she went on and she did well for such a long time on the clinical trial. When she did finally progress, it was just in a local lymph node. I was able to radiate that, and they let her stay on the clinical trial. And we kept treating. And so she ended up total time on that clinical trial, almost 2 years.
Mhm.
And just imagine where you are now. It's already 3 years. You've already had, lurbinectedin and maybe platinum, and maybe coming back to lurbinectedin. But if you got another therapy in there now, if there's a clinical trial available, and if you get any good amount of time out of it, a year, 2, who knows how long, could even have a complete remission. But we won't know unless we try. The thing about the clinical is, number one, you're watched very closely. So you're going to have labs, during that first week on the clinical trial, you may get labs 2 or 3 days, and then the EKGs and all of the things that come along. And then you're going to be visited with probably the next week and so on. And then the imaging is going to come quickly. So if you're having toxicity that really says you shouldn't continue the therapy, you'll come off trial. You'll get imaging soon. And then if that imaging shows you're not responding, you can go on to something else.
Mhm.
And
Okay.
the thing that I hate and that I don't want to ever have for my patients is that we miss a clinical trial opportunity doing standard of care. And then by the time we come back to the clinical trial, there's an organ dysfunction like kidney or liver dysfunction, low blood counts, or either just the patient's just not feeling well enough to do the trial. And then we end up excluded from the trial at that point when we could have qualified for it before. You can always come back to your doctor and do standard of care. When my patients go to our phase 1 clinic, they go to a particular doctor, but they still come back to me. They call me, they text me, they keep me updated on how things are going or any concerns that they have. That way they don't feel like, they've lost anything. And if anything changes or it doesn't work, they just come right back to me and we pick the next thing and keep rolling. So I feel like if the trial is an option, at least hear about it. But understand that if you go on a trial, if it doesn't work, you'll be imaged soon enough to find out. And if you
Okay.
have toxicity that makes you feel bad, you'll come
Okay.
off, so it's worth considering.
Okay.
Yeah.
Okay. Thank you.
Thanks,
Okay.
Rayanne. I see Wendy next with her hand raised.
Wendy's on mute too.
Oh, okay. I was gonna say I saw Wendy. Now where did she go? Okay. Oh, there she is.
On my mute button. Thank you. Hi, Wendy Brooks. I'm limited small cell. I was diagnosed July 7th this year. So I'm just close to completing my carbo topside treatment. My 4th round will be starting this Thursday, and I've completed 30 rounds of radiation to the tumor in the upper left lung. But my question has to do with the molecular testing. Is that a standard that should be done each time there's a biopsy, or what? Can you go into depth a little bit more about that? And one caveat with the hospital that I'm affiliated with, the cancer center, it is affiliated with the university, and I did agree to have my slides banked for research testing, so they do have that. But yeah, if you could explain that a little more, I'd appreciate it.
Yeah. So right now in small cell lung cancer, next generation sequencing is not really standard. And there are some people that will say, why are you doing it? Because there's not going to have any implications for your patient. And I disagree with that. It may not now, but it may 5 or 10 years from now. And so again, I think we won't know unless we actually get the information. But before I say all of that, number one, congratulations on getting, near the end of your treatment and for doing well with that. So I know it's not easy. My favorite thing is to tell my patients, your hair will grow back, but mine won't. So we make that joke all the time in clinic. And I was going to make it one day, and this guy, he always wears a hat. And I just thought about how I haven't seen him without this hat before. And I was making my joke, and he pulled his hat off and he was like, I don't have any hair. What are you talking about? And I was like, oh, this time my joke failed. But anyway, yeah, right now in small cell, it's not a standard to do the molecular sequencing. In academic centers, they're probably going to do it. If they have their own in-house test, they may do it. But right now, it won't change our clinical practice or what we do for first or even second line therapy. I will say that one of my colleagues, Dr. Jacob Sands, did find an EGFR mutation in one of his patients before with small cell lung cancer, and they went on EGFR targeted therapy and actually had a response. So the question is, was that an EGFR mutated non-small cell lung cancer that transformed to small cell and just maintained its EGFR mutation? And in which case it could respond to therapy, but that's very rare, very. And so right now it doesn't really kind of inform what we do in first or second line therapy. And with small cell, we really want to move quickly. And so delaying to wait on those results when it's really not going to impact what we do is really kind of unethical. So we don't wait on the results, but I do think that getting the test done and then looking for it. Another thing that I can do with my test, the blood-based testing, and this is not standard practice yet, is to follow circulating tumor DNA for my patients with small cell or non-small cell. So we're on therapy, chemo, radiation, and I can look at the trends in the circulating tumor DNA levels to kind of inform response to therapy and also to look for evidence of relapse of disease later. So this is one of the ways that I'm using circulating tumor DNA. Again, this is all still in clinical trial and a part of many clinical trials to look at circulating tumor DNA levels and assess those. So it's not standard of practice yet or standard practice. So if that wasn't done for you, don't feel like you missed anything.
Thank you. Yep. And I'm, look, I was diagnosed, like I told you guys, in 2006, and I just got genetic testing done in the last few years. And I figured the same thing you did. It might help someone else in the future.
That's right. Yeah.
Anyone else? They could come off mute. Oh, I see Christopher.
Hi, Dr. Porter. Thank you so much for doing this. I'm a caregiver for my mother who was diagnosed with extensive small cell lung cancer this past May. And my question is in regards current options for immunotherapy with the growing use of immune checkpoint inhibitors in the treatment of small cell. I was wondering if pseudo progression is possible with this disease, and if so, if you've had any experience encountering that among the patients that you've treated.
Yeah, so pseudo progression, for those of you who don't know, I'm sure many of you have heard of pseudo progression, but when we start patients on immune checkpoint inhibitors, pseudo progression is something that can happen. And pseudo, basically I call it fake progression. And when I was outside earlier today, I got bit by a mosquito, and my arm, my hand, my wrist is swollen here. Okay. Why? Because there's an immune reaction, there's inflammation in this area. And so it made it swell a little bit. And I explain that to my patients because we may come for that first treatment and see that the tumor got, bigger by 8% or 10% larger, Then in that case, was that just inflammation as the immune system came in to start to work in the tumor microenvironment and caused, fluid retention in that area and just the tumor to look a little juicy? That can happen. The way small cell lung cancer usually responds to therapy, it just kind of disintegrates. It melts, kind of like butter. So, and more like a lymphoma, actually. When I think about the imaging characteristics as we see response and how rapid of a response we usually see. So I think that there's definitely probably a time, if we catch an image at the right time, that we may catch pseudo progression in small cell. But usually I feel like it regresses so fast that we may miss that window. Somebody comes in with new shortness of breath after starting therapy last week or 2 weeks ago, and I get a CT angiogram and rule out a pulmonary embolus. I may see the tumor has changed a little bit and maybe even gotten a little bit larger. That's the time where I may expect to catch pseudo progression in small cell, but I wouldn't be discouraged because it's only been 2 weeks. Let's just keep going and give your body a chance to actually get rid of this. And then we come back and look at the appropriate interval for imaging. And I usually don't see pseudo progression in small cell, but I'm not saying it's not possible. Other organs that can be involved with small cell, like the liver, you may see a completely different immune response in the liver. And so because of that, maybe you can see pseudo progression in some of these areas. And if I think about places where I may see a little bit of growth, but not really get kind of discouraged by it with my patients is the liver is one of those places where I'm likely to just give them a little bit more time on therapy and give it a chance to see the response that I'm hoping for. Sometimes they don't respond in the liver. And if you think about it, you don't want your immune system ravishing your liver. I do want to do some basic science work to look at the liver parenchyma and look and see if it's secreting any immunosuppressive substances or molecules, interferons, or any of those things that may be immunosuppressive, because we do see different response in liver compared to other organs with small cell and non-small cell with immune checkpoint inhibitors. But all that to say, pseudoprogression is definitely always possible. If it's 20 or 30%, you really need to be suspicious that that may not be pseudoprogression. But if it's just slight enlargement of the tumor, then that's definitely a time where we should consider and then look to see when we actually started therapy versus the image to make sure that it's not just too soon to see the response expected.
Mhm. Thank you. No, I asked that because actually my mother has a sort of history of very like hypersensitive reactions to treatments. She, developed like anaphylactic symptoms when she started chemotherapy. She, had systemic skin reactions and starting immunotherapy. So it seems like she always gets a really vigorous response to these treatments. So when I'm thinking about, her sort of first post-treatment scan coming up on the horizon, I'm thinking about sort of these possibilities because when I had read that it was tied to, sort of the almost like an overreaction of the immune system. So I was trying to see if that was a possibility. Thank you.
Yeah. Well, I hope our first scan looks fantastic. I believe it will. And a lot of times what we see is patients who get skin reactions and all of these things from immune therapy actually have an abundant or a kind of robust response from the immune system. And we can see, even if they can't continue therapy, sometimes that they have prolonged tumor control because of that robust immune response that they've gotten to cause some of those other systemic immune mediated side effects. So it will be interesting to see the imaging. I wouldn't expect pseudoprogression, honestly. I think that she's probably just going to have a good response and we'll see a nice tumor regression.
Thank you.
Mm-hmm.
Thank you. I have another question from Jan.
Hi, Dr. Porter.
Hey there, Jan.
My name is Jan, and I was diagnosed on May 24th with small cell lung cancer limited. And I've went through 30 rounds of radiation, and I've done 4 chemo cycles. And the question I have is about scans. My doctor requested a PET scan, and unfortunately, my insurance said it was too soon after treatment, and they denied it. And she appealed it, and they denied it. So she regrouped and sent me for a CT scan with contrast. And I want to know, should I feel comfortable that she says the CT scan was favorable and she saw all the information she needs to see in that. And so I go tomorrow for my 5th round of chemo, and I'm a little concerned in that I guess I don't know what the difference between the PET scan and the CT scan with contrast. Does the PET scan light up the cancer cells where the CT scan doesn't? And I was almost to the point where I told her I'd pay for it myself. And so I guess that's my concern. They did the CT scan shows a 4 by 5 millimeter micronodular opancy is seen in the left upper lobe at the prior site of a larger speculated mass. So that's the only thing that I'm reading out of here. And they did do it for my abdomen and pelvis as well, and there was no findings there. So should I feel comfortable with that CT scan?
I need to know one thing, Jan. What do you remember which day you finished your radiation?
I finished the radiation on August 17th.
Yes. Too soon for a PET scan.
Okay.
I would not do a PET scan this soon after completing radiation. It's only been about 5 or 6 weeks. Okay. And the PET scan is still going to be hot from the radiation therapy. So what we're going to get is false positive PET scan results, and we won't know what to do with it. Are we going to go back and re-irradiate you or re-challenge you with 6 more cycles of chemotherapy? Absolutely not. So right now, the PET scan is still going to be falsely positive, and we usually wait about 3 months before we do those PET scans. And
Okay.
I trust the CT scan in that interim. I really do. And it sounds like you had an amazing response with only a 4 or 5 millimeter?
It was 4 by
micrometer?
5, and I'm not looking at the original one, but I had a pretty big tumor, and she seems to think that it's might be scar tissue that they're seeing. And I am meeting with her tomorrow, and she is sending me for the 5th round of chemo, which was always in the plan anyway.
Yeah, so 4 to 6 cycles is reasonable. And, I think if you've had a good response and you can still tolerate more and aren't having too many side effects from the chemotherapy, it's reasonable to go on to cycle 5 and cycle 6. But I do think it's too early for a PET scan. That
Okay.
area will still have avidity from the previous radiation. But, if you finished in August, then by November, maybe December, it would be reasonable to do one, especially if we ever see any growth. But you may not ever need another one.
Okay.
But I don't think it's wrong to consider doing one. It is just too early.
Okay, good. Thank you for that. And I went through chemo with no side effects whatsoever. I'm
That's
a little
fantastic.
tired. I'm not looking forward to that part, but I've really been the poster child, I call myself. So
That's
I'm just
awesome.
praying everything goes in this direction moving forward.
Yeah,
Thank you
that's
so
amazing.
much.
Yeah.
Thanks, Jan. And look, I could a testimony for you for that because my tumor was 15 centimeters and I still have what they believe is scar tissue
Mhm.
remaining.
Okay, thank you.
And I have a question in the chat. My husband was on Timodar, I have not heard of that interest, for a small cell lung cancer brain mets, and after 2 cycles, some tumors disappeared, but new ones appeared. I'm confused as to how it can be working and not working at the same time. Do you think this is just because of how aggressive this cancer is?
Right. So I do have a question in response to that first before I can answer. Number one is, had the brain been radiated? And the the Temodar, for those of you who don't know, is also called temozolomide.
Oh,
And
yes.
it's an oral chemotherapy agent that we use also in glioblastoma and GBM and some other diseases. But it gets good central nervous system penetration, so it can be an effective therapy in the brain. But even outside of the brain, we know that there are some subtypes of small cell that may respond to Temodar and a PARP inhibitor, which is a type of drug that we use in ovarian and breast cancers as well. These are oral agents also, so it's 2 pills, Temodar and olaparib, or Temodar and talazoparib. And so we can put that combination together and not only get responses in the brain, but also in the rest of the body too, for certain patients who have certain mutation types in small cell. So if the brain was radiated, then it may be reasonable to go back and do some pinpoint radiation, or, some of you may know it as gamma knife or cyber knife, to those areas in the brain that have continued to progress. If he's already had that and there's other places growing, then we should probably consider whole brain irradiation. And then the therapies that we rely on to get into the central nervous system don't always get there in reliable concentrations. And so it could be that there's a issue with the actual absorption in the central nervous system, but then there could also be subclones of the disease where one part is responding to the Temodar and another part is not. So if we biopsy any tumor from one spot to just a couple of millimeters left or right and biopsy, there's a chance that the thing that's driving that tumor at the molecular level is not the same. And so when we see kind of discordant response, responding here and not responding there, it may be that there's something different molecularly about those. And we know metastatic sites can have different characteristics at the molecular level and even at the proteomic level. So for that reason, there may be, just a discordance in the response, but getting back to what is really standard for taking care of intracranial disease is to be sure that the radiation that we typically use has already been done. And if it hasn't, then we should go back and revisit those more kind of typical approaches. I'm assuming that has been the case, that the radiation's been done, but I've had patients that I've sent back for gamma knife to places that broke through or we started with gamma knife and small cell, which really wasn't standard until more recently. People are doing that. And I believe it was Mr. Bishop who said that he was deciding about the prophylactic cranial irradiation. So, if you didn't do that and then you have progression, then it's reasonable to do that now for your husband. I think Lisa was the one with that question. So
Yes, thank you.
Yeah,
So-
I hope I answered it.
My husband did have whole brain radiation initially. He had 10 rounds. And when the progression happened, they said that gamma knife he wasn't a candidate for. So they weren't able to do any more for him.
Gotcha.
But I was just kind of, you answered my question. I was just a little confused as to how some would be going away and new ones coming. It just didn't make a lot of sense to me.
Gotcha.
But I understand. Thank you.
Okay. Yes, ma'am. Thank you. And Mr. Bishop, if I was just going to say now, this is not for medical advice at all. You have to, make your decisions with your physician for sure. But if your physician recommends, watchful waiting without the prophylactic cranial irradiation right now, I think it's reasonable. A lot of people are doing that now, but as long as you're going to be able to go in and have the imaging done that's recommended to follow up your brain and make sure everything is safe there, because radiation is usually very exquisitely active in the central nervous system for small cells. So my patients who are all of my long-term survivors at some point had brain involvement, and we have treated that and they have done fine. So without doing treatment up front. So I feel like if that's what your doctor's recommending, or if that's what you're leaning towards, it's definitely a reasonable approach, but it just needs to be followed very closely. So if your doctor's recommending an MRI every 3 months or something like that, as long as you can get in for that, then I think that's a reasonable way to do that.
Okay, yeah, it's the side effects that I've been warned about that scare me, about doing the radiation without having any symptoms of having anything in my brain. And, you get cognitive problems and, the whole list. I'm sure everybody's heard them. So they're pretty negative, yet the upside didn't seem like it was great. Like as far as if you did get cancer, the survival rate was not really that big a difference, is what I heard anyways. I don't know if that's true.
No, I feel like it's true because the disease is usually so responsive. And what I have had for sure is people get prophylactic cranial irradiation, and 3 or 4 years later, they haven't had progression of their disease, but they're starting to have some side effects from the radiation. So there are times when we kind of want to avoid that in limited stage if we can. So if that's if that's an option for you, it's definitely worth considering.
Yeah. Okay. Thank you.
Yes, sir.
Thank you. We have another question in the chat. How frequently do you recommend CT scans with contrast and MRI of the brain with contrast?
So I think this is where I differ from a lot of my colleagues, because this one is kind of a matter of style. And some people will 3 or 4 months between scans. I'm not that patient. And I'd like to know, and it took a lot for me to even calm down and go to medical school, because I grew up with instant gratification. And so to have to train myself to wait through medical school residency and fellowship to actually get to be a doctor. When I was in high school, I was like, I just want to be a doctor. I don't want to do this or this or this. I don't want to go through these steps. I just want to be a doctor, and I want to be a lung cancer doctor, and I'm ready to go. Let's do it. And I got very discouraged when I found out that I was going to have to take a religion class and then these English courses. And I was like, I've been speaking English for 20 years. I don't have time for this. Let's go. And so I got discouraged. So anyway, I've never been the type of person to be very patient. And so I usually image every 6 to 8 weeks while we're on active therapy. For my limited stage patients, once we get to surveillance, it's every 3 months. And it has to be like clockwork. And if I can squeeze it in 10, then I will. And then for extensive stage patients on active therapy, it's usually every 2, no more than 3 cycles. So 6 to 9 weeks, and we're doing our next images. For the brain, I'm probably in limited stage, when we're in surveillance, if we didn't do prophylactic cranial irradiation, I'm usually scanning every 3 months. And then for patients who have extensive stage, who still haven't had brain involvement, then I'm getting an image every 3 months. There are some times where I go 6 months, depending on kind of the characteristics of the disease. But usually it's every 3 months for those patients with the brain imaging.
Okay. And I have a question in the chat. Oh, sorry, Mate, I'll come to you after I ask this question. I saw your hand up. And this one, I believe, is still in clinical trial, but we'll ask the question. What is your suggestion concerning testing for DLL3 if the local labs cannot stain for this protein?
Well, so far, the plan for DLL3 is not to give this therapy based on expression levels of DLL3. So I don't think that it's something that we should really be concerned about right now. Now, we are in all sense talking about personalized therapy and targeted therapy. So to imagine not staining for DLL3 is kind of counterintuitive and a little bit concerning for me. But eventually, I think that once DLL3 is available and the therapies are available, like tarlatamab, then we'll see that DLL3 staining may be done as a part of the molecular profiling that we do at the beginning or at diagnosis prior to treatment. But right now, the anticipation, because DLL3 is so highly expressed, but it can also be variable. So that means that, yeah, where I biopsied, I didn't see DLL3 expression, but does that mean any of the other diseases not expressing DLL3? Not necessarily the case. We may have expression in one area, but not expression in another. And so with those kind of changes between the expression, we don't want to withhold DLL targeted therapy or DLL3 targeted therapy from patients based on the lack of expression from one biopsy that was partially necrotic anyway. And right now, the plan is for that to be a more general therapy that's available for people, regardless of DLL3 expression. So I don't think that we have to be worried about that right now. But it's similar to the subtyping that we discussed earlier. It's not widely available. But as it becomes relevant for our cancer care and our patients, then it will be available for use in clinical decision making. So for right now, I'm not so concerned about the DLL3 staining.
Thank you. Did that answer your question? Okay, yep. And Maida, did you have your hand raised?
I did. This might be a too personal question. I don't know. I was diagnosed, doctor, 5 years and 2 months ago, which is phenomenal. And I've given my doctor and my little granddaughter all the credit for my still being here. But what I'm concerned about is I did not have prophylactic brain radiation, and my doctor was fine with my not getting. But as much as I get a CT scan, a chest CT every 3 months, and I'm having another MRI of my spine because I have growths in 4 vertebrae, not concerned with my getting another brain MRI. And the had was last February or March, wondering if I should be, because that's 7 months.
I think you're breaking up a little bit, but I'm pretty sure I got that your doctor is following your CTs closely and the spinal column, the vertebral body's being watched closely, but you don't feel like the brain is being watched as closely. So, when patients come to me concerned, it's so easy for me to press a few buttons and order a test, and 7 months is reasonable to say, we're going to go ahead and look at your brain. And so I think that number one, 5.5 years, I think is what you said. That's a long time. And I'm excited about that. And I think the chance of you ever developing brain involvement is going to be very low. But I still think that it's reasonable, especially if you're concerned, to just say to your doctor, hey, let's look at my brain. Don't even ask. Just say, hey, let's look at my brain. And it's like, oh, okay, and press a few buttons and the MRI is ordered. And then you can have your peace of mind, and not have to wonder. So if you're ever wondering, just bring it up, and for the doctors who haven't figured out yet that we're a team and we're making, decisions together, you may be the one to help him figure it out or help her figure it out. But it may just be that if we had that checklist that we were talking about earlier, then you could come in and just say, hey, it's time, let's do this.
The thing is, he is a great doctor. He's been fantastic.
Yeah.
And this is the only place, but you're right. I am going to contact him and say, let's schedule that. Thank you.
Yeah. And it's really not that she's not a great doctor. We know she is, but how many patients is she seeing, and you look fantastic. So she's probably not thinking, the other day I had a guy who at the end of our talk, they put him in a room and get his vital signs and everything. So I go in to see him. He's already on the table. We examine and we talk and we discuss this, a new diagnosis. And we're getting up to walk out of the room and he stumbles to the right in my peripheral vision. And I was like, what was that? So I turned around and I'm like, are you doing that a lot? And he was like, doing what? He had no clue what I was talking about. I was like, you stood up, you stumbled to the right. And he was like, well, I don't think so. Well, you stumbled to the right. So his MRI brain shows brain metastases. Okay. You don't look like you're stumbling to the right, Maida. So your doctor's probably not, it's not front of mind to say after all these years, hey, let's get a brain image, but it's reasonable to do.
Yeah, well, I have agility with my dog. I fell about a foot on a hard driveway and wrecked my knees and my shoulder, but it was just carelessness. So
yeah.
I missed the step. But thank you, Dr. Porter.
Okay, yeah.
Okay, great. Oh, and I have a question in the chat. My husband was diagnosed 12/22. He had an MRI of the brain in January 23. He completed chemo and 30 radiation cycles and was scanned on 8/10. It was clear. He's not due for another scan till the end of November. He was feeling good, but now is very fatigued. No appetite and swallowing is difficult. I feel they are dropping the ball with him. Should we make demand? He is now on Tecentriq every 21 days. Tomorrow will be his 4th infusion, supposed to be on it for a year.
So I would say with the weight loss, the dysphagia, trouble swallowing, yeah, you should be concerned. And I wouldn't call it dropping the ball as much as I would. Are they even aware of the symptoms? So with these changes, how long has it been? One thing I can say is that immune therapy can cause anorexia. So I have some people on immune therapy and they just really have a decreased appetite. And then that leads to weight loss. And so we get their images and there's still no evidence of progression of their cancer. But what I do in those senses, I'm very aggressive about managing the anorexia, because when people are losing weight, their association with weight loss is that their cancer is not responding to therapy. And so I don't want patients or their families to have the distress of that. So I try to treat them and get the anorexia under control. But if you're actually having dysphagia, that's a different thing. So number one, we need to be sure that the esophagus is okay. Because with immune therapy, you can get immune-mediated reactions of any mucosal surface. And we think about ulcerative colitis is the colon, but Crohn's can happen anywhere from your mouth to your anus. So if you get an immune reaction in the esophagus, it may make it hard for you to eat, and then weight loss from that. But then we also know that small cell can have large central lymph nodes. And I'm trying to show you my esophagus and coronal area, where these things if lymph nodes are growing in that area, can compress and cause some trouble. Another thing is that if you've had radiation, if it included the central portion where your esophagus is, you may get esophageal strictures that make it hard for you to swallow. And so we have to be sure that that's not the case. So I think that, I would definitely bring it up and say, these are the things that we're experiencing. Can you look into them before you just because a lot of times my patients say, well, I knew I was going to have a scan, so I just was going to wait and see. Or I knew I was coming to see you. I've had diarrhea for the last 2 weeks, but I knew I was coming to see you, so I was just going to let you know. So the doctor, don't not tell them. Say everything. The mucosal surfaces is front of mind for me because I got a lady on an immune checkpoint inhibitor who came in with just blisters and sores on her mouth, and her son and her daughter-in-law, who's on the phone, are saying, well, we were suspecting that it was the therapy, so we just wanted to ask you. I was like, well, you should have called my nurse and let us know. Like, don't suspect it. If you think it's the treatment, we need to do something about it. And so she's on steroids now for a week and steroid mouthwash or magic swizzle with some steroids in it, and she's doing really well. And this is all healing, but I'm holding her treatment for now. We could have got into trouble with that though, where we ended up in a burn unit with some real serious issues. So please bring those up to the doctor and tell them you really want to kind of look a little bit more closely because you're worried about those things.
Oh yes, she also said he also has gastroparesis. I hope I'm saying that right. Yep, as well as Barrett's esophagus. He is scheduled for an endoscopy.
Oh, perfect. There you go. That can evaluate for stricture, and then with Barrett's you can get esophageal, lesions and cancer. So all of that needs to be evaluated. So I'm happy he's scheduled already.
And I was going to ask this question myself. Diane wanted to know also, can we get copies of the checklist?
Oh yeah, we'll get you a checklist.
Anyone else? I can't see everybody's hand, so you might have to come off of mute or put it in the chat.
I think it was a great meeting. I learned a great deal. And some of the things that you took time to explain, I went through myself, and it's good to hear a doctor without charts. I'm not a chart person. I've never been that. And I don't relate to charts, but the way you present the information, I really appreciated tonight. It was very thorough and, so we could understand it. So thank you.
Well, that means everything to me. Thank you.
If I'm in Tennessee, I want to come to your clinic. Look, Christine, I see your hand raised.
I just want to say thank you to you for presenting so well.
Mhm.
I am a caregiver of my husband. He was diagnosed mid-April, SCLC extensive. And, I love doing these Zooms. I'm glad there's, a place on Facebook that I can reach out and say, help, But yes, thank you so much for your time.
Yeah, absolutely. I know that you have other people too who are available for you and as a resource to help. But if there's anything I can do besides, I don't have to be presenting. Anything that I can do to help, please let me know. Because when I think about every day and I think about my family and our history, there's nothing else that I would rather do and I've been, I haven't been the patient, but I've been the caregiver. I've been there with both my mom and my dad. My mom had cholangiocarcinoma while I was in medical school. So I have a caregiver experience that I think a lot of other people may lack. And so I understand and don't mind spending the time. So please, remember me if you ever have any questions or need anything.
Thank you. Thank you.
Thank you.
Thank you so much, Dr. Porter.
And so I need it because sometimes patients ask me questions that I cannot answer because I don't have the experience. But when you are together and to hear, the similar stories with the chemo and radiation between Jan and Wendy, you have a connection, you understand. I could see Wendy's, head nod while Jan was talking because she knows. And so there are things that as much as I know I can read every book, I won't be able to say, and I won't be able to necessarily relate to who knows what's going to happen in life, but not yet anyway.
Thank you. Any closing words, Dr. Porter, for us? Or?
No, just that I know I don't know you, but I love you all. And I didn't know really what to expect. And this was amazing and it's invaluable. It's so goofy because I love my patients. I talk to them on the phone. They call me. It's nonstop. And we're all friends. And so I just feel like I got to really hang out with a cool group of people. So thank you so much.